things that have been discussed with regards to why is the phenomenon taken on in China and India, and most explanations come down to the conclusion that it has to do something with increasing socioeconomic status, better health care, and therefore better support for people with mental illness. If you look at the WHO database and you look into Egypt, it says that above all age groups, the suicide rate is 7.2 per 100,000. Worldwide, it's 10.5. So you can see here that Egypt has a lower rate than the world mean in suicide. It's not readable here, but you're somewhere in the middle, and the North African countries, they're pretty stable. These are the rates in male, these are the rates in female, so it's beyond the purple line, it's the blue line actually. And there's a bit of a decrease here as well, but it's pretty stable, but on a very low level. When looking into suicidal ideation, and these are data from a larger systematic review, you see that suicidal ideation is very common in adolescents. 20 to 24% say that they thought about taking their lives. In Germany and Austria have rates of 39% of all the adolescents reporting suicidal ideation at one time point here until they are 18. And you can also see that suicide attempts are pretty common. 3 to 9% worldwide said or report that they attempted suicide once in their lives. One has to say that the most recent data I could find about Egyptian youth were from the Global Youth Wellbeing Index, including 30 countries. And of these 30 countries, it was the 5th best, meaning very low suicide rates in the age group of adolescents, only 4 per 100,000. So it's nearly the same as my home country, Austria. We have 4.6, so a bit higher, but it's about the same range of suicidality in youth, meaning those 15 or up to 19 years of age. I'll spare you that one, but this is just suicide rates in different countries, and you can see here that in youth, that nations like New Zealand, for example, which historically has always a very high rate in youth, also Russia, or Lithuania, they are among the states with the highest suicide rates. And one thing that I'd like to talk about is age. And you can see here the age of ideation, plans, and attempts. And you can see here those are the ideations, and they seem to take off at 13 to 14 years of age. So ideation started a bit earlier than plans and attempts, which is normally something that you could see in 14 to 15-year-old ones starting off. And this is a graph showing, and these are data from the US, from a huge CDC sample, but this is a very interesting data as this graph shows you how fast does actually a plan turn into an attempt. So this is the line here, and you can see that within 1 year of those who planned suicide, nearly 60% attempted a suicide. So if you think about risk assessment, and this is a crucial thing, there are a lot of adolescents who think about suicide, but if you're sitting across the table from an adolescent who has a concrete plan how she or he will commit suicide, then your alarm bells should ring. So what happens to those suicide ideators? There are very little data on the long-term outcome. This is data from the Great Smoky Mountain study, so this is US data as well. So they followed them up 7 times between the ages of 9 and 16, and 4 times between the ages of 19 to 13 years. So you have adults by now looking for the long-term outcome. By the age of 16, 4% had a suicide attempt, so this is pretty much as you would expect. And the suicide attempt predicted suicide attempts in adulthood with an odds ratio of 6.4, so you raise the odds by 6, which is tremendous. So those who attempted suicide in adolescents have a fair chance of doing it again in adults, so they are a prime group for prevention. And suicide attempts in adolescents were also a predictor for anxiety disorders later on in their life. It increased the odds by nearly threefold. And you can see here there are the 4 scales of functioning in the Great Smoky Mountain study. So this is general physical health, this is risky behavior, this is financial situation, this is social situation. And you can see here that those with an attempt, which are the red ones, they fare worse in each of these 4 domains in comparison to those with just ideation and plans and those who never had any suicidal behavior whatsoever. So this is a huge predictor of what's going on later in the life. Well, these were just a few numbers, because I know that numbers are boring, but just to give you a scale of what we're talking about, it's a huge amount of youth that are thinking about suicide, and also a lot of youth who are attempting it. But what about risk factors and prediction? And I know that there are a lot of models trying to describe the phenomenon of suicide. I picked up Joiner's model because I like it. It's an easy one. I really like it. You can group a lot of research questions around it. There's been a lot of literature on that. And what Thomas Joiner said in his interpersonal psychological theory of suicide is that there are three factors coming together. The first factor is that there's perceived burdensomeness. So they have a feeling that, for example, their family would be better off if they were dead. The second thing is thwarted belongingness, meaning that they don't have a feeling that they belong to a group. Of course, this is nothing new. Evan Ringler wrote about that nearly 70 years ago now, using other terms, but saying, for example, that social isolation is a major risk factor. And then, and this is something that this model adds, from my understanding, which is really new, that Thomas Joiner said, suicide is not an easy act to commit. You have to be brave to get to the point where you commit a suicide, and you can get there if you have an acquired capability. So people don't start off suicidal, but they can acquire the capability for suicide either by thinking about it, planning it, having a lot of rumination and thoughts about it, or they train, for example, by self-injuring themselves, although they're not doing it with any suicidal intent. I'm going to talk about that tomorrow. But they train of hurting their body, they train of crossing a line, and they train for pain. This is one of the possible explanations why non-suicidal self-injury, although it's non-suicidal in its nature, is a major risk factor for suicide attempts and suicide, as we've seen in the literature of the last years. So there's a wish for suicide on the one hand, perceived burdensomeness and thwarted belongingness create that, and then there's an acquired capability to go for suicide. And only if these two come together, there's some sort of danger. And looking into mental health disorders and suicidality, these are quite recent data from a 10-year prospective study, including 3,000 adolescents, following them up, and they were looking, or they had the idea of, so what are the mental health diagnoses that predicted suicide best in a longitudinal study? And the highest rates were found for PTSD, as you can see here, and dysthymia, as you can see here. Of course, the usual suspects like panic disorder, anxiety disorders, also depression on this list as well. But you can see here that it's some sort of a cumulative thing. So this is a survival chart for those with 1 disorder, 2 disorders, 3 disorders. So the more disorders you accumulate, the higher your risk for attempting suicide. And these are one of the very few data sets that have shown through a longitudinal set that really there's a risk coming from certain diagnoses. In this case, it's PTSD. Another risk factor is sleep. And this seems to be something that is especially found in adolescents. It's a predictor for suicidal ideation, attempts and suicide, and this is not just data from association studies. These are really data from longitudinal studies showing that even if you control for psychiatric conditions, because of course somebody who is depressed also has some sleeping problems, but even if you control for the psychiatric conditions, sleep or sleep disorders remain a significant risk factor for suicide. So this means if you assess suicidality, never forget to ask how they sleep. And if within the last couple of days sleeping somewhat decreased, changed, if they have the feeling that they can't go to sleep, are awake at night. So this predicts suicide ideation and attempts, and it also predicts suicide in longitudinal studies. Another thing that seems to be quite adolescent specific is, of course, bullying. And the interesting thing is that not only the victims have a higher rate of suicide attempts and suicidality on a whole, but also the bullies themselves. This may be explained because we know that a lot of bullies have a history of being a victim, and some of them even change their role. in different social systems. But we can see here in both data from the Great Smoky Mountain study as well as from the LSPAC, so two longitudinal data sets from the UK and from the US, that being bullied at age 13 predicts suicidal ideation and suicide attempt. So increases your odds threefold at the age of 15. So next step, ask for bullying, ask for social exclusion, social ostracism going on. This is just cross-sectional data from Germany showing that it's even kind of, for those who've been frequently bullied, it increases their odds for suicidality sixfold. And when talking about social stress, and this is what bullying is all about, it's always interesting to look into neurobiological systems that are involved in social stress. And I'm pretty sure that all of you have heard about the cortisol response when you get in a stressful situation. So what was done here is they were doing the TRIA social stress test, which is a classic social stress paradigm. So what you are asked to do is you're in front of three persons, they're all in a white coat, there's a video camera pointing at you, and you're asked to introduce yourself, tell something about yourself, and then you're asked to solve mathematical equations. So, and the thing that I have to tell you, the three peoples, they are not giving you any feedback. It's not like you nodding and saying, oh, I'm still here, I understood what I said. They're not giving you any feedback at all. So they're just sitting there watching you, because they're instructed to do, and this leads to an increase in cortisol, which is a good thing, because an increase in cortisol is the normal stress reaction and can lead to the feedback loop and the downregulation in our stress system as well. So an increase in cortisol means in that situation that your body is taking every single measure to make you perform. And you can see that increase in cortisol here as well. That's the normal, so the healthy controls. But we do have two other groups, and these are the ones with suicidal ideation only, the dotted line, and then you can see here a group who have committed a suicide attempt. So they have a blunted cortisol response in that social stress paradigm, which doesn't mean that they're especially cool, because they're really stressed out, and you can see it on the videos and rate it, and they feel stressed out, and it takes them longer to come down with the stress level because the cortisol response is not working. And this is a longitudinal study, that's why I brought it up. So they were actually looking on the long term, does this cortisol response predict suicide attempts? And in the future, the answer is yes, if you combine it with somebody who has a high level of peer stress. So the combination of bullying plus a blunted cortisol response seems to be a predictor of suicide attempts. And let me be clear, this is not something that we could use as a tool to predict suicide, like doing a TRIA social stress test, doing a setup of three people with white coats and then measuring your cortisol response, because these are all, as you can see here, very recent studies and all been done in large groups. But there seems to be a signal here that they are not reacting to social stresses as other youth are. You can see the same signal. I'm talking about that tomorrow, just a teaser in those adolescents with non-suicidal self-injury. It has been replicated over and over again. This is a very nice paper because it actually tried to retrieve risk factors for suicidality from a longitudinal study. And these are the risk factors that came up. There's one risk factor saying that seeing self-harm in other persons, in your friends, in your family members, is a risk factor. Having any sort of mental health disorder, and you can see here the adjusted odds ratios for depression, anxiety, and behavioral disorder, which were the top three. Being a female gender for suicide attempts, for suicide, it's the male gender. Having a lower IQ, high impulsiveness scores, lower consciousness on the Big Five model, more adverse life events, less satisfaction with the body, hopelessness, and smoking or an intake of illegal substances. All of them showed up to be risk factors for suicide attempts in a longitudinal aspect study. Thinking about methods of self-harm, there's a huge study that linked 5 Swedish registers together to see if they could say something about the suicide risk based on the act of self-harm or the method of self-harm. And they found that overall, on both genders, violent methods compared to intoxication has a higher hazard ratio for suicide risk. For females, cutting had a hazard ratio of 4.0, and violent methods on the whole had a ratio of nearly 4. For males, the influence of the methods didn't matter. And this has probably to do with the fact that males almost always choose more lethal methods of self-harm when you talk about suicidality. The problem is that if you use a more lethal method or a more violent method, your chances of dying in a suicide attempt is much higher, and this could explain the higher rates of suicide in males worldwide. There are other explanations for that as well. For example, that males perceive somebody themselves to be somebody who doesn't need help and is not asking for help and is particularly not going to see a mental health specialist. That could be another reason why they die young. And the same is true for any physical complaints. But here it doesn't matter, probably because most of them are using violent methods. So there are some tools out there that had the idea of capturing suicidality in a standardized way. And I'd like to start this part of my talk with a huge disclaimer, saying that although there are scales that you could use for risk assessment, and they could aid you in risk assessment, and they could be in a chunk, they will never be able to weigh something. And that's somewhat of the sort of the art of suicide assessment, because scale can capture risk factors and do it in an appropriate way, but there's no such scale that has ever shown that it could predict suicide in the long run. So it's something you could use as an aid, but not something that you could trust on. So one of the most prominent scales, and there's a lot of research on that, is Kelly Closen's Columbia Suicide Severity Rating Scale. There's a lot of materials for the CSSRS online. There's even a course you can do online, a rating course. You can find all the materials for download for free in different languages. So I think it's a tool that you need to talk about because it's so widespread, and there's at least some evidence that it helps us in determining suicide risk. So it's built like there are 4 constructs. You have suicide ideation severity, that is on a Likert scale. You have the intensity of ideation, so it's about frequency, duration, controllability of thoughts, deterrence, so what keeps you away from a suicidal act, and reasons for ideation, also to be seen on a Likert scale. Then you're asked for actual behavior, so did you do something? Was it an aborted suicide attempt, an interrupted suicide attempt? And this makes a difference. What would you guess, which is the higher chance for suicide? Those with an aborted or those with an interrupted attempt? Any guesses? Who will commit suicide far more likely in the future? Those you came to see with an aborted, or those you came to see with an interrupted attempt? Those with an interrupted attempt have a higher chance to commit suicide later on because they didn't choose to stop it. It was another people's decision. Parents were coming into the room or something like this happened. Whereas those with an aborted, they did some preparatory acts, but some where in the act stopped. They have a better outcome. And lethality for actual attempts. So if you have somebody sitting in front of you who actually had a suicide attempt, you can rate lethality here on a 6-point scale. But if you have a 0 because you didn't do any attempt, then rate the potential lethality of his thoughts. And there's a lifetime period. You have any question?
I have a question because we were used to for a term called suicidal gesture.
Yeah.
And we meant by this people who are not seriously attempting suicide. This suicidal gesture is considered risk or not?
That's a very interesting question. I just finished a paper on that because suicidal gesture, there is very, very few literature on that if you look into it. And although there are a lot of adolescents doing it, so we found that in our clinical sample we had around 11% who said that they had done some suicidal gesture, as you said. So I did something, and I never wanted to die. And I knew that I was not going to die from that, but I did it to get some reaction. This would be a suicidal gesture.
Do you consider it a suicidal ideation, or just because
No.
of personality problem, or
What else problem? Maybe a lack of attention, but it's in the model of knock. It wouldn't be, although it's called suicidal gesture, it would not be considered a suicidal behavior,
it's not
because
suicidal?
the intent is not suicidal. They want to have something else.
Okay.
And this is really interesting. We were looking into the functions of suicidal gesture, suicide attempt, suicidal ideation, and they differed, interestingly. So the function of suicidal gesture would, as you would have expected, was a social one. So they wanted to gain something from others, whereas suicidal ideation, suicide attempts, have a lot to do with themselves and trying to, have some sort of an emotion regulation or get out of a situation or found their circumstances of living unlivable anymore. So this is something it has to be differentiated, and thank you for the question, because I'm fascinated by suicidal gestures, and they seem to be very prevalent actually, or even suicidal threats, where people say to somebody else, I'm going to kill myself, but know that they will never do anything like this, that they're just saying it to receive something from the person. And they will be considered as non-suicidal actually.
Because parents become very afraid, and they ask us, I have to stay with them 24 hours, or what the child shall do?
Yeah.
And if you tell them it's just a gesture,
I would never tell them it's just a gesture, because if you refrain for a suicidal gesture to get the attention of somebody, you have a huge problem. And this is the thing that I always say to parents, because I always have, or sometimes you encounter parents where they say, I'm not taking this seriously. I mean, this is just a gesture. And you said, okay, but do you consider it a normal form of communicating your problems if you have to refrain to a suicidal gesture to be able to manage and, get the form of reciprocal relationship that you're looking for? So I would not see it as a suicide risk factor, but as a risk factor for a severe problem, and also a severe problem of communicating about their needs. Yeah,
the term parasuicide
Yeah.
has too many meanings. That's what
I-
for predicting. Is it a suicidal gesture that with no intent to die, or is it non-completed?
Thank you very much. Another great question. The term parasuicide was used very often by Marsha Linehan, and she still uses it to that day when she publishes. And it's some sort of a very broad term encompassing both non-suicidal self-injury, suicidal attempt, suicidal ideation, and suicide gesture. So she's lumping everything together that's somehow maybe comparable to the concept of self-harm, but she's not differentiating as Matt Nock is with regards to, is there an intent of suicide that's underlying the behavior or underneath the behavior or not? So I'm not quite happy with parasuicidal actions as a term, because it's very undefined. And normally what I find in my clinical practice is that adolescents can tell you whether they did something with or without suicidal intent. It's not a problem for them. It's not something that they have to think about. They can clearly say, I wanted to die, or I didn't want to die, or I knew that this was not going to happen. They can tell you. Of course, there is, as always, ambiguity, but normally you get a very good answer if you ask that question.
So you prefer not to use the term?
I got away from using the term long ago, so I know that there's discussion about it, and there's a discussion to be had, for example, for self-harm as well. So I see it more as an umbrella term, like self-harm, and then there are different self-harming behaviors beneath the umbrella term. But for clinical assessment, I think you need to be more precise and cannot stick to the umbrella, but need to understand what was the intention of the adolescent. So this is the CSSRR, just to show you, it's a two-pager, you don't have to read it, it's unreadable anyway, but you have this fields you can go on, and you have lifetime and past month, and you can do a yes/no, and there you have to go from 1 to 5, as I told you. So it's pretty straightforward, and you create some sort of a sum score. It can be used in research, so that's something nice if you're going to do research, and it might aid you in your clinical assessment, so that you don't forget to ask certain questions, but it's not... You use it, yeah? Yeah. There are a lot of Arabian and a lot of versions worldwide, so it's an 8, but I think you have to... It doesn't... it should not stop you from thinking, actually. You need to talk to the patients and not just go through a screener. Yes, go on.
Just a question. Actually, there's some studies that with low score, people sometimes do suicide.
Yeah, and that's, I'll show you some. I've got everything summed up on a slide, actually. It will come later. We don't have a very good specificity in suicide assessment tools, plus we don't have a very good sensitivity in most of them, which is the one that you were looking for if you are looking for a screener. And I think the problem is that you could, of course, ask for risk factors, and we know a lot of risk factors, but for me, suicide is not a linear thing. It is a very dynamic approach. So there are persons with all of the risk factors who go through their life not thinking about suicide once. And then there are persons where things accumulate, and then they're left by their girlfriend, school's not going right, they lost their job, and suddenly within a very, very short time frames, I'd like to compare it to a tsunami, things get overwhelming. And if you keep them safe for a couple of days, you can often see that this goes down as well. So with these risk scales, the problem is that they are more looking into suicidality as a linear sort of things, whereas we have to understand it very dynamically. And this is probably the things where scales are working to a degree, but they are not really convincing in the long term. There's also a screener, I don't know if you know that, for the CSSRS that makes it very short, gives them some color coding. Of course, red is the high risk, and you can go for yes, no, and it's the same thing, but it's very short if you want to have a screener. So here are the data I promised you. So there's a study, that's the original study of Kelly Posner in adolescent suicide attempters, and they followed them up for 24 weeks. And they said that the worst point, suicide ideation, and suicide attempt history predicted further suicide attempts within these 24 weeks. Well, this is something that we knew already. And then there's, just from adults with a mean age of 33, a psychiatric cohort, but a large cohort. So this is a really nice study, following them up for 6 months. And they also found that the worst point, suicide ideation intensity, like in Kelly Posner's paper, and the total score predicted suicide attempts and suicide within the 6 months. But when I have a look here, for the prediction, the best was suicide ideation intensity with a cutoff of 18.5 points, and a sensitivity of 59% and a specificity of 57%, which is not optimal to be on the positive side here. And the total score had, with a cutoff of 28.5, a sensitivity of 69%, so it's getting better, but sensitivity is something that you would like to have from a screener, not from a tool that you really use in this practice, and the specificity of 54%. This is not optimal still. And there's a very recent systematic review of prediction literature in adolescence, so they included 11 studies on 10 tools, and for self-harm, there was some possibility to have a 3 months prediction for self-injurious thoughts and behaviors. The suicide ideation questionnaire showed a poor sensitivity, a very good specificity. The self-harm questionnaire for 3 months, self-harm had a very good sensitivity and a poor specificity, so that would be the ideal screener here. And for suicide attempts, the best you can get is actually for a screening, the Ask Suicide questionnaire with a sensitivity of 96%, sorry, and a specificity of 6%, so this is an ideal screener. There's a suicidation questionnaire junior version here as well. There's a hazard ratio of 1.323, and I've talked about the CSSRS. The suicidation questionnaire for adults was not able to detect suicide. And then there's some behavioral measures. The CDR-SR is the children depression rating scale revised, and there was higher risk or increasing risk by 1.3 for 10-point increase. So the authors recommended that there is no single tool suitable for predicting a higher risk of suicide or self-harm in adolescent population. So this is what they came up with. And then there's another kind of depressing paper, but everybody who's doing suicide assessment should really read these 50 pages. So it's a thick paper if you print it out, and Joe Franklin summarized 50 years of suicide research, everything that has ever been published on risk factors. And can we predict suicidality? He included 365 longitudinal studies and did a meta-analysis. And he said, well, there are top 5 predictors for suicide ideation. It's earlier suicide ideation, hopelessness, depression, a history of child abuse and neglect, and anxiety disorder. For suicide attempts, it's non-suicidal self-injury, earlier suicide attempts. Screening instruments can tell you something about the risk and earlier psychiatric hospitalization. And for suicide, it's an earlier suicide attempt, an earlier psychiatric hospitalization, earlier suicide ideation, lower socioeconomic status, and adverse childhood experience. So these are the top risk factors. But prediction, by using all of this, is slightly better than chance. So you could flip a coin with everything we know and don't get a better outcome. This is kind of depressing after 50 years of suicide research. And there was no increase in knowledge in the last 50 years. So we didn't move forward in a way that we got better in predicting suicide. And he said that there are new methods that are necessary for suicide risk assessment instead of everything we know. And a lot of people are playing around with these new methods in the last couple of years. So one method could we use big data to get better prediction? And this is a data set of 2 hospitals. They followed up patients for 15 years. They have 8.9 million patient years involved in the analysis. It thinks that you can only handle with computers. And they found that they could predict the suicide with a sensitivity of 45% and the specificity of 90% by applying their computer model. And of course the old usual suspects popped up in that analysis. These are all the mental health things. So you can see here the odds ratios are quite high for substance abuse, depression, stuff like that. But they also found new things in their analysis because they're not just included everybody who had a mental health issue, but those were all the patients ever seen in those hospitals. And they found things like hepatitis C, osteomyelitis, and injuries to be also linked to suicides. And people have applied the machine learning models to adolescents as well. So there's a comparison of those used with suicide attempts, used with self-harm, depressive youth, and controls from hospital. And they found out of this big data analysis another predictors. Some of them are pretty well known, like age, like PTSD, ADHD, and so that has been intake, antipsychotic medication, or gender, or major depressive disorder, SSRIs. But then you can see there are some things like pain medication, the intake of ibuprofen, that popped up as well. Another field is trying to get around asking direct questions. And how could you do this? I don't know if you've heard about implicit association tasks. So you're presented with a computer screen and things pop up on the screen, like for example suicide. And you have 2 buttons and you need to decide whether suicide belongs to death or to life. Easy choice. Is it death or life from your perspective?
Death.
Death, yes, very good. But then the thing is that there is a second category, like not me and me. And then you have words like me, mine, I, and you have to sort them as well. And you have to be quick. You don't need to think about it, just be quick. And the way that people sort, they tend to, at least I show the data, those with a history of suicide attempts tend to sort me or I more often in the same direction than death, interestingly. So this is what have been couple of studies going on. So this is the German version that we did, but just to show you that the colors keep changing. So if you have a life or death decision, this is a one color, or if you have, is it mine? Then you go for the green structure. But also you can calculate the D-score. It says here that it's the mean answer time, so you're going for the answer time. Incongruent trials versus congruent trials. Incongruent meaning that life and not me, this is an incongruent trial, where life and me would be a congruent trial. And you calculate that, and the positive D-score says that there's a stronger association between me and death and not me and life. And you can make studies with that, and they're kind of interesting to look into. So there's a suicide IAT in psychiatric emergency room patients in adults and a 6 months follow-up. So and the implicit association with death was higher in those with a history of suicide attempts. But in the follow-up, and this is the interesting thing, there were also a significant association with the D-scores. So this was did also work on the long run or in a longitudinal setting as a predictive measure. Then you could also do it online. So if you want to really try out an implicit association task, go into Google and Google implicit association task. There are numerous IATs on the web that you could do for yourself and find out interesting things about you. There are also IATs telling you whether you hold racist beliefs or not. This is one of the most common IATs. But you have to declare that you're taking part in the study because, of course, people are using this in online samples. And they also found in the online sample that the IAT was sensitive for acuity of suicidality and intensity. You had higher scores in those with potentially more lethal suicide attempts and with more recent suicide attempts. And then looking, we did our own study, of course, in adolescents as well, and it worked out pretty well. As you can see here, those are the D-scores with no suicidality at all. These were all psychiatric child molested inpatients. Those with a suicidal ideation, this is last month, this is last year, and you can see here a difference in those with a suicide plan. So this seems to differentiate different groups of suicidality. And one thing that I'm, being somebody who works with fMRI, is very interested in neural signatures of specific concepts. This has been done in suicidality as well. So to give an example, if I show you a spoon in the scanner, you would give me that reaction. So you have an increase in activation in motor cortex and in gustatory regions, and this is a neural signature. It's there in everybody who ever used a spoon, and it makes total sense because if you use a spoon, you take it, so your motor cortex is normally activated and you taste something. That's why the gustatory regions go on. And if I show you a house, you have an involvement of parahippocampal areas and parietal areas. And these are the studies, I don't know, they've gone through the press like 2 years ago saying that now scientists can read thoughts. It's obviously far from that, and this is luck. We're still not able to read thoughts, but it's something that different things come up where if you just put this sort of pattern to a computer, it can tell you that the person looked at a spoon without knowing it, or at a house. So the question was, do we get the same signal for suicidality? Is there a chance of getting patterns recognition so you don't have to talk to the person? Although this is of course a very costly procedure, and these are very preliminary data. So you can see here it's only 70 with suicidal ideation compared to 70 healthy controls, and they presented several concepts, and then they presented words. And as you can see here, I somewhere put them into red. There were 6 words where there was a pattern recognition possible by the computer. Those with suicidal ideation activated the brains differently than those healthy controls. And these words were death, carefree, good, praise, trouble, or cruelty, of all the list of words that were given. And then they trained a machine learning algorithm with these 6 concepts, and the pattern that you'll get in the fMRI scanner, and then the scanner was able to correctly identify at least 15 out of the 17 with suicidal ideation. So this is another frontier of suicide risk assessment that it's not applicable to clinical assessment in any way at the moment, but just to show you what are the things that a lot of people are doing research on. Here are the brain regions where they differed. Rather those with the suicidal ideation, they had a higher activation in those regions in comparison to the controls with the green ones. And they had a pretty good accuracy and sensitivity with those analyses. This is my last slide because before I go over to clinical assessment, this is the thing that everybody's talking about now. It's the combination of different assessment methods, using variables, using ecological momentary assessment, and to see and to really get into the lives of persons and to see where is the moment that everything accumulates and to get a feeling for that. So you could look for escalation of social dysfunction, of emotional stress, of sleep disorders. And for example, what can be done for emotional stress? Well, your smartphone or Alexa or Siri is pretty good at knowing in which mood you are in. So voice analysis and pattern recognition of emotion is not something that is really new. It's working already. You could look into the language that is used. For example, the things that you text on social media or on WhatsApp. This is very easy using linguistic word count inquiry. You can look for the emotional tone. You could look for a facial expression. So everybody unlocking their smartphone with their face knows what these machines can already do, and they can also recognize emotions. You can look for heart rate. If you have a wearable like an iWatch or a Total Watch or whatever you're wearing, you can look for heart rate variability. And of course, all those variables knows your choice of music. And if you feed that into an algorithm, it can get better at telling how you feel. You can have social dysfunction if you get pattern recognition of online communication or the movement. So are you moving out of your house? Are you seeing other persons? Or are you not? And of course, you can go for sleep disorders. If people wear wearables, you can see whether they are awake at night, if the patterns of sleep have changed or not. So all these things are things that we already have and that are already working. And now the question is, can we combine them in a useful manner? We're going on to clinical assessment, and I'd like to start off with a case here. So this is a 14-year-old named Sandra. It's brought by her teacher to the psychiatric department. Classmates have told the teacher that she was posting about a plan to attempt suicide on WhatsApp yesterday evening, and they informed the teacher. When the teacher talked to Sandra, she said that she had thought about committing suicide on a daily basis the last couple of weeks. The teacher wasn't able to reach the parents, so she decided to come with Sandra directly to the psychiatric department, which was a wise thing to do. And my question to you is, what do you want to know from Sandra? What are the things that you are asking for in your daily practice? Yeah, go on.
How long has she been struggling with this ideation?
Very good. So onset of ideation, yeah. Louder.
Does she have a plan?
Is there a plan?
Does she know
Yeah.
what is she going to use to kill herself or take her
Yeah,
life?
you want to exactly know the plan. So what is the method? Is it a very... So from my clinical perspective, you always get those adolescents say, well, I don't know, take some pills. And I said, okay, have you already ordered the pills? Do you have pills at home? Or which pills you're thinking? I don't know, maybe things I found. So they are quite ambiguous, whereas I encountered adolescents who said, you know, there's the train coming here at 4 p.m., 21 minutes. I've been there twice and looked at the spot where I'm going to jump and I'm going to the... So these are the persons that I don't want to go home, whereas the first with the more ambiguous plan is something that you can think of. Yeah. Anything else you want to know?
Previous
Is it the first
attempt,
time?
self-harm.
Previous attempt self-harm, is it the first time?
This is the first time for suicidal ideation.
Yeah, very good.
Family history?
Sorry?
Family history.
Family history, very, very good.
Who are the support system?
Yeah, very good. Is there a support system? Yeah.
Other symptoms of depression, other symptoms of
Mental health,
personality,
disorders.
other...
Did you sleep well?
Did you sleep well? Thank you very much. Yeah. Sorry?
Recent stressors.
Recent stressors, yeah. Very important when we think about the cumulative things.
School environment.
Yeah. Is it okay? Are you under stress? Are they supporting you? Are you ostracized?
I would
Other
like to
medical
ask her
conditions.
why she told the teacher and not parents.
She didn't tell the teacher. She told it on WhatsApp, actually. Sorry, she posted on WhatsApp, yeah. Which is, at least in Austria, very common these days. We've got a lot of those kids being dragged in by the police, actually, because people show it to the police and the police will get the IP and get the person behind the WhatsApp message.
Any other medical condition?
Chronic diseases, disorders, medication is taking. Very good. Well, what shall I do now? Because you had all these things, so what should I tell you? So, there are some messages I want to convey. The first is, you can relax. Because talking about suicidality will sure do no harm. There's no way of getting this wrong. This is always something where if you're new in the job, you're kind of shaky. But the one thing you can really do wrong is not asking for suicidality. As soon as you ask, you're on the winning side. And this has been done in actually randomized controlled trials. So both using self-report measures in schools or using personalized interviews. This did not create any increase in suicidality. So you can ask people without harming them. Isn't that a good thing? The only thing you can do is win here. Because asking seems to feel relieving for those with a history of a suicide attempt, interestingly. And this is the point where I wanted to show you a video, but I fear that my loudspeakers are not loud enough. Oh yeah, they aren't. No, you can't hear it at all.
Can you put the mic next to it here?
Oh, that's a nice idea. Okay, but before I try this and make fun of myself, I have to explain how this video came on. This is actually a video that we did. This is a video that we did for an e-learning course because in 2015, 2016 we had a lot of young adolescents coming in from Syria, Iraq, and Afghanistan. So we quickly had to develop knowledge for the people working with them. How could you do this? And this was an online course we did for professional helpers. And this is actually a film telling you how can you work with somebody who is translating. And the young person you see is not an actual patient, so this was just, we did this for an e-learning, this was a research fellow, and she was from Egypt. So when I got the invitation, I was like, I'm going to take this video because I'm talking in German and it's translated to Egyptian, Arabian forms. So I don't know actually what they are really talking. So I will look very closely at your, at how you're reacting to that spot to see if that works. But maybe we can try the microphone trick. So I'm trying to do this. Getting it as loud as possible. No, it won't work.
Damit ich genau verstehe, was gesprochen wird. Vielleicht wollen Sie das jetzt schon mal übersetzen, was ich gesagt habe, damit Rina weiß, worüber wir gesprochen haben.
كلام دلوقتي الكلام الدكتور هيتكلم فيه هترجمه بنفس الحروف نفس العبارات من غير ما ازود او اقلل اي حاجه. الكلام ده الخطوه دي انا بقدر اترجمه بنفس الطريقه اللي هي اتقالت بيها.
Also Rina, kannst du mir vielleicht sagen, wie du zu uns gekommen bist? Was hat dich hierher geführt?
ممكن تقول لنا ايه اللي ازاي انت جيتي هنا المستشفى، ايه اللي حصل لك خليتي هنا؟ Mit Sozialarbeiterin, die Frau Fellmann, in Südland gesprochen und sie hat einfach erzählt, wie es schlecht geht und sie hat mir einfach empfohlen, zu kommen.
beschreiben, wie du dich fühlst.
تقدري تشرحي يعني حاسة إن أنت حزينة أو زعلانة ممكن تشرحي لي حاسة بإيه؟
وأنا مش حاسة بالإحباط مفيش أي حاجة بتحسنه بيجيلي أفكار كتير وصور مخليش أنام
Also eigentlich schlagen, hoffnungslos und die immer wieder Bilder die ganze Nacht.
Do you understand anything, or shall we just
We
skip it?
cannot hear.
Okay, okay. Yeah, we'll just skip it. I think it's not. It's useless then. But it was Arabian, though, and it made sense. Okay. Okay.
The Arabic was good, actually.
What?
The Arabic was